To thank Miguel Valdivinos for having the vision of putting together this session and inviting me to speak at this session. I've really enjoyed my time here in Mexico. I am going to cover a great deal of information today, and I've promised the translator I would speak slowly. So I'm going to highlight for you some really important points so that you will be able to score higher than 20% when you're managing your patients. And everything I'm going to tell you today is going to be very, very practical. You can learn it today and take it to your practice later this week when you return from this conference and make better choices with your patients. We're going to first speak very briefly about anticipating the risk of GI bleeding related to these drugs. We call anticoagulants and antiplatelets collectively antithrombotic drugs. We're also going to spend a fair bit of time on the new management paradigms for both the elective setting in the endoscopy arena as well as in the acute setting after the patient has bled. And all the way through this talk, I'm going to leave you with actionable, practical cardio-GI tips that are evidence-based and the source of all the guidelines that you saw, because I had the opportunity to work on both of them, so that you can make really good choices with your patients going forward. The first thing I want you to understand is bleeding from these drugs is extraordinarily common, and as our first speaker highlighted, is likely to increase even more with the aging population. If you just look at atrial fibrillation patients over the age of 65 years, and these are all American numbers, there was an estimate of about 3.5 million patients who were eligible for chronic anticoagulation therapy prior to the entry of the first novel oral anticoagulant, Pradaxa, on the market, who were not getting any drugs because they didn't want the risk of GI bleeding or other hemorrhage. And that risk is about 0.3 to 0.5% with warfarin, and we know the risk with the direct oral anticoagulants or the new agents is slightly higher. And that's translated to between 13,000 and 23,000 GI bleeds per year in the United States. We also know that after a person has had an acute coronary syndrome, about 10% of those patients will bleed or have another hemorrhagic complication in the first year. And these hemorrhagic complications are 80% of them in the GI tract. As I mentioned at the postgrad course, this isn't an inconvenient complication for the patient. We now know from the cardiology literature that having a GI bleed after an acute coronary syndrome event related to the drugs that they place you on has a profound impact on your prognosis. The 1-year mortality and the 1-year cardiovascular related mortality goes up almost 4-fold. So having a GI bleed is a predictor of a bad outcome for a patient. So our ability to prevent them and treat them properly becomes very important. And we also know that this isn't a phenomenon limited to the United States, but occurs all through Europe as well as Asia. I've shown this slide before if you were at the postgraduate presentation to highlight how frequent these bleeds are. In this manuscript that we published in Circulation in 2013, we highlighted the number of upper GI bleeds, lower GI bleeds, transfusions for GI bleeding, and hospitalizations for GI bleeding in a population of about 78,000 elderly patients. And what struck the cardiologists, and which is the reason why we published it in Circulation, was how frequent it is. We've expressed this in terms of the number needed to harm. How many patients would you need to put on one of these strategies as a cardiologist to induce one additional GI bleed? And what you see is the numbers are all under 50, and in some cases under 25. So that's very few patients needing to be treated with these drugs to induce a significant GI bleed. Now, with that first study I shared with you was done during the days of warfarin as the only anticoagulant option, and we now know that with the new direct oral anticoagulants, the risk of GI bleeding goes up. We have recently published studies of head-to-head comparisons of these drugs to show that when it comes to GI bleeding, there is a safer and a worse option for these new agents. Rivaroxaban is the worst for GI bleeding. As you can see, it only takes 45 patients to be prescribed prescribe rivaroxaban as opposed to apixaban, which is the safest for GI bleeding, to induce a GI bleed. But the one thing I'd like you to remember is that regardless of the agent, new novel agent that is prescribed, once you hit the age of 75, your risk of GI bleeding increases threefold. So by the time you're age 76, warfarin is actually the safest option, and we've published that before. And I'm just highlighting for you in this most recent publication how the protective effect of apixaban becomes even more apparent for protection from GI bleeding as you age. I wish these drugs were only were not combined, but were only prescribed as monotherapy, but unfortunately they're not. And here I've shown you a meta-analysis comparing the key findings of GI bleeding across all the major clinical trials that used triple or complex antithrombotic therapy using a new oral agent. And what you see is that there is a very narrow risk-benefit threshold. When you look at the number needed to treat, 77 patients would need to be treated with these triple therapies to prevent one cardiovascular bad event, but only 111 would need to be treated to induce a major GI bleed. And that's why cardio-GI becomes very important, is because patients are being prescribed these drugs, are having events, and once they do have a GI event, their prognosis changes. So we need to think about this in a multidisciplinary fashion. So with that as background, let's look at the elective setting. As our first speaker shared with you, one of the most common strategies for antithrombotic therapy is dual antiplatelet therapy. And that is a strategy that involves the treatment of patients with both aspirin and a phenylpyridine agent, often Plavix, clopidogrel, ticagrelor, or prasugrel. And you can see from the American guidelines of the American Heart Association and American College of Cardiology that these guideline recommendations for the use or the continued use of dual antiplatelet therapy gets longer and longer and longer every time there's an iteration of these guidelines. So what we're seeing here is that there are there's a large at-risk population who are on these drugs that are at risk of GI bleeding for a much longer period of time. So you are going to see patients in endoscopy for elective procedures who are on these drugs. It becomes imperative that you understand how to appropriately temporarily interrupt these drugs to save the patient from a cardiovascular event while preventing a post-procedural bleed. These tables are all the tables that they included in the American Society of Gastrointestinal Endoscopy guideline. So that guideline is entirely based on our work. So if you want to have a copy for yourself, I would recommend you pull that guideline and mimeograph those tables. But here what you notice is depending on the antiplatelet agent, the time for interruption prior to your endoscopy is different. You can't just hold every agent for 5 days. The reversible agents, such as ticagrelor, need a shorter period of time. And then the very long-acting drugs like vorapaxar need almost up to 2 weeks. So it's very important to know what the drug the patient is on so you can hold the drug appropriately. The second most important thing to remember is that when you hold the phenylpyridine agent, you must continue the cardiac aspirin. All right? I get at least 2 or 3 calls every quarter from a gastroenterologist or a gastroenterologist lawyer or a patient's lawyer asking for expert witness testimony, which I do not do, because the gastroenterologist has forgotten to continue the aspirin. It is not a medically defensible position now, given the literature we have, all right? So you can hold the phenylpyridine for the appropriate time period, but you must continue the cardiac aspirin. And that's based on this literature, which shows you that as long as you continue the cardiac aspirin, which is shown in the yellow bar, there's you have a fair bit of time before the risk of thromboembolism goes up for the patient. In the pink and the green, you see that within 7 days, if you stop the aspirin and the phenylpyridine either simultaneously or one after the other before endoscopy, the patient has a very high risk of clot. But if you continue the cardiac aspirin while holding the thienopyridine, you can keep that patient in a safe zone, which is why all the guidelines in the United States, Europe, and Asia all support the continuation of cardiac aspirin during temporary interruption of antiplatelet agents. There are a couple of periods of time, though, when I want you to think twice about holding dual antiplatelet therapy, all right? And this is because there are 3 golden periods of time when the patient really needs that thienopyridine, and mono antiplatelet therapy with aspirin alone is not sufficient to protect them. That is in the first 90 days after acute coronary syndrome. It doesn't matter if the patient is treated medically or treated with coronary intervention. You do not want to stop the dual antiplatelet therapy at that time. But that's not the time to be doing an elective endoscopic procedure anyways. So defer the procedure, which is what we would recommend. And then the other 2 times are after stents have been placed, and we're going to talk about those a little later. But here again is the guideline recommendation to remember. You can do any endoscopy, even acute GI bleeding management, safely on aspirin monotherapy, all right? So if you take home one big ticket item from today, a cardiac patient who is on cardiac aspirin for secondary protection, not people who think it's a good idea because their aunts told them to do it, but because they've had a heart attack or stroke. Cardiac aspirin is the most important thing to keep a patient on. And in the absence of that, you will put yourself at medical legal risk if you stop it. And here's the data that supports that. The pivotal trial was by Joe Sung, published in the Annals of Internal Medicine in 2010, which showed that there was just too important a mortality difference in patients in whom cardiac aspirin had been withheld. In this study by Sung in Hong Kong, these were all patients with upper GI bleeds who at the time of management had had their aspirin and their antiplatelets held, but then after the treatment for their bleed, they had been randomized to placebo versus aspirin after endoscopic hemostasis had been achieved. And certainly, there was a reduction in the 30-day rebleeding rate. But look at the 30-day mortality rate. Only 13 patients had to have their cardiac aspirin held before one death. And death is not an outcome we want, right? It's not one we can explain. There has since been a number of other large studies showing the same results. And this slide tells you why it's not a medically defensible position to hold cardiac aspirin. Let's turn now to the acute bleeding setting, okay? We're going to talk about blood transfusions and platelet transfusions. The Villanueva group in Barcelona really put on the map the concept of the restrictive blood transfusion strategy as being protective from mortality for patients with GI bleeding. And as you read that, as someone who sees myself seeing mostly cardiac patients or GI bleeders in general, I think that makes a lot of sense, but I was wondering what the role would be in cardiac patients. And remember, in cardiac patients, there's a fine balance between restrictive transfusion and the induction of demand ischemia. So if you read these results in a cardiac patient, you want them transfused to a level of 10. But even the American Heart Association and the American College of Cardiology agree that we do not need to get them to 15, right? 10 is sufficient. But let's talk about platelets, because this has been a hot topic of debate for a long time. There has been this belief that many of these cardiac patients are on antiplatelet drugs, such as Plavix, that are going to kill their platelets for 7 to 10 days. So if they come in with an acute GI bleed, doesn't it make sense to give them a platelet transfusion? This is a paper that came out of Lauren Lane's group in Yale and was published in Clin Gastro and Hepatology in 2017. And I've reformatted the results so that they look similar in presentation to the Villanueva paper. And what you're going to see here is a very common theme. There was no difference in any of the GI bleeding outcomes in terms of recurrence or the induction of cardiovascular events among those patients who had received the platelet transfusions, but there was a 6-fold increased risk of death. Now, this isn't a perfect study. It's a case-controlled study, and certainly the cases who received the platelet transfusions could be considered sicker in many ways than the controls. But what I'm highlighting here is that there's a principle, a physiologic principle of transfusion medicine that's showing itself here, and that is blood products, whether they're packed red blood cells or platelets, are active substances, and they induce reactions in the body that have since been shown to cause increased mortality when they're transfused inappropriately in a number of settings. We're just late to the party in some ways in discovering the impact of inappropriate blood transfusion and a platelet transfusion in GI bleeders. This is a field, this area that's going to evolve in GI bleeding management, but for right now, we would recommend the following clinical pearls for antiplatelet-related bleeding. You want, in an acute setting, it's okay to stop the phenylpyridine because remember that effect on the platelet lasts about 7 to 10 days. But you want to maintain the patient on an aspirin monotherapy when you stop the phenylpyridine. The 3 periods of time when you do not want to stop the phenylpyridine is when it's less than 1 year after a drug-eluting stent has been placed, less than 30 days after a bare metal stent has been placed, and less than 90 days after the acute coronary syndrome event. Those are the 3 periods of time when the risk of either stent occlusion or sudden cardiac death goes up, okay? Those are the only 3 times. You should be doing no elective procedures during that time anyways, but if you're treating an acute GI bleed, you still need to remember those 3 time periods, okay, and have discussions with the patient and their cardiologist about the risks of stopping the phenylpyridine. Remember, the dual antiplatelet therapy effect lasts 5 to 7 days, so that's why even in an acute setting, you're probably going to be safe. Do not give platelets. I don't have the time to take a show of hands, but I suspect a lot of folks in this room are routinely giving platelet transfusions to these patients. You should stop, all right? Because we're now seeing more and more medicine, papers coming from transfusion medicine showing the increase of transfusion reactions leading to death. Most important thing, once you've done your procedure, you've got hemostasis, restart the dual antiplatelet therapy. The biggest mistakes we see are people who forget to restart the aspirin and the phenylpyridine. That's what gets them in trouble. One very important slide that I think every gastroenterologist deals with is what to do about the patients who bleed in the acute cardiac setting, right? In the post-acute coronary setting where they're getting glycoprotein 2B3A inhibitors and heparin drips and something's going to bleed, and big doses of aspirin. Here's the key concept. The risk of inducing a lethal arrhythmia, VTAC, with endoscopy is the highest, about 12% in the first 24 hours after the acute cardiac event, all right? But when I trained in the early 90s as a GI fellow, our attendings used to say, if you get a call from the CCU, say thank you very much and back away. You just do not go to the coronary care unit. We now know that that's not true. The highest risk of endoscopy is in the first 24 hours, but after that, the natural epidemiologic curve is that the risk goes down quite precipitously after that. So when should you consider doing endoscopy after the first 24 hours? If there's still evidence of active bleeding. Hemodynamic instability, despite the use of pressors and aggressive resuscitation, hematemesis or bright red blood streaming out of the bottom. You have to go in there because in 83% of the time you're going to find a high force class lesion that requires your attention endoscopically, because that's not what's life-saving for the patient. They need that lesion dealt with endoscopically so that they can go to cardiac cath. And 43% get there faster if you've dealt with the endoscopic lesion, all right? So this is not an elective time. This is an acute time, but after 24 hours, you should be considering going back in there if there's still evidence of hemodynamic instability. I'm going to turn my attention to warfarin, because even though we have novel agents, this is still the most common anticoagulant used around the world, and there are some important paradigm shifts in the acute setting that I bet a number of you may not be aware of. It was traditional when you had a supratherapeutic INR bleed for us to give fresh frozen plasma to reduce the INR, because we had two false beliefs. Number one, that we needed a normal INR in order to do our job. That's false belief number one. And false belief number two was that if we gave 2 or 3 units of fresh frozen plasma on the way to the endoscopic unit, we were making a difference. Well, we're going to talk about false impression number one on the next slide, but I'd like to focus on how do you appropriately reverse a supratherapeutic INR. Current guidelines do not support the use of fresh frozen plasma, and that's because you need very large volumes of fresh frozen plasma to reduce an INR that's, for example, to reduce an INR from 3.95 to 2, you would need 5 units transfused slowly over 9 hours. That's not what any of us do. So whenever my fellows tell me that they've ordered FFP, I always say, is that for you? Because that's clearly not for the patient, right? Doesn't make a difference. Now the Americans have all moved to the use of 4-factor prothrombin complex. It's been found to be more cost-effective and more effective for reducing the supratherapeutic INR, and more importantly, it does not cause the transfusion reactions. Vitamin K can still be used as long as they don't have a valvular heart disease, right? Because valves can have, there's a rebound hypercoagulation that can happen. But remember, that's not going to be helpful if you plan to do endoscopy that day or the next day, because it takes days for that effect to happen, all right? So if you want to do it quickly, PCC, prothrombin complex, is the way to go. Here's the slide to slay the dragon that makes you think you need a normal INR. All right, we have a number of studies. Some of the best data actually comes from the Canadians, the rugby registry, that shows that you can achieve excellent hemostasis and post-hemostatic endoscopic outcomes with a moderately elevated INR. What is that? That's an INR between 1.8 and 2.5. Now, any of you who have participated in the creation of guidelines know it's like making sausage. You put a whole bunch of stuff in the mill and something different comes out. Originally, when we created the 2016 Acosta guideline, we had put 2.8 as the top limit of where you could safely do endoscopic hemostasis based on the evidence. But the Board of Governors of the American Society of Gastrointestinal Endoscopy was very uncomfortable with that threshold, so we compromised at 2.5. But the Brits have agreed and the Asians have agreed, so we're all on the same page. Do not need to normalize an INR to successfully treat a supratherapeutic INR bleed. Once you hit 2.5 or less, you're good to go, all right? The most important thing you can do after you get in and do your business is restart the warfarin. And there have been a tremendous number of studies in the cardiac literature showing what happens when endoscopists fail to restart the warfarin. What happens is the risk of 90-day thrombosis goes up. I still see patients who have had their warfarin held for 2 weeks after a warfarin-induced bleed, which is terribly inappropriate. We now know from a lot of literature that there's a sweet spot, and that's between 4 to 7 days after the warfarin gets discontinued. Restart the drug, okay? 4 to 7 days after you stop the warfarin, get them back on their warfarin so that the patient has limited risk of recurrent GI bleeding, as you see, non-significant, and a very low 90-day thrombosis risk. We're going to now turn our attention to the direct oral anticoagulant endoscopic pearls for management. 3 principles, again, a major paradigm shift. You need to know the post-procedural bleeding risk of your endoscopic procedure. You have to understand the patient's inherent risk for thromboembolism with temporary interruption of the drug, right? Because that is supposed to be your moment of thinking of respectful temporary interruption. And the most important thing that you need to know is the creatinine clearance of the patient. Remember, all these drugs are excreted by the kidneys, so there will be increased residual anticoagulant effect in patients who have impaired excretion from the kidneys. So everyone says, oh, the INR is normal. INR is not helpful for direct oral anticoagulant. And they say, oh, the creatinine is normal. The creatinine is not helpful. You want to go to the next column over in your labs at the creatinine clearance, or in some labs it's reported as the estimated glomerular filtration rate, eGFR. That's the number you need to hone in on, because that's the number that dictates the period of time or the length of your temporary interruption before the endoscopic procedure. All right? Let's very quickly look at the procedural risk for GI bleeding. As you can see, most of our diagnostic procedures are considered low risk. You can do them without stopping any antithrombotic. But if you're going to be taking off large polyps, doing variceal band ligation, sphincterotomy, EUS with FNA, endoscopic hemostasis of any kind with cautery, laser, or APC, endoscopic mucosal resection, or any kind of bougie or savory dilatation that causes large fields of mucosal disruption, that's a high-risk procedure. And our colleague didn't tell us what that risk is, but high risk is considered anything with greater than a 1.5% post-procedural bleeding rate, okay? Here is the important one table I want you to know, and again, it's in those guidelines, those American guidelines, that shows you the thromboembolic risk. The line to remember is the pink line, okay, right at the top. Who are the patients in whom you cannot be lazy or sloppy with your temporary interruption? They're the patients with mechanical heart valves, right? They're also the patients who have had a heart attack or stroke within the last 3 months. They're the patients with recent DVT, PE, or inherent thrombophilia within the last 3 months. And they're the patients who have a CHA2DS2-VASc score of over 5 if they have atrial fibrillation. Okay, these are the people who are very high risk of thromboembolism, even on their anticoagulant, so you don't want to be inappropriately interrupting their drug. But here's the drug chart for you, and you'll see that the first column is the creatinine clearance, which is why you need to know 2 things. What drug is that patient on? What is their creatinine clearance? And when was their last dose? Because that will tell you how many days you should interrupt that drug before you do endoscopy with a high post-procedural bleeding risk. And you can see, first of all, anybody who has an impaired kidney, a creatinine clearance less than 60, really shouldn't be on a direct oral anticoagulant. And if you've seen a lot of GI bleeds in patients on direct oral anticoagulants, look back at their creatinine clearance. They probably all had impaired kidney function. They were all over the age of 75. That's why. They shouldn't have been on the drug in the first place. So, one very quick slide. I get asked a lot, is there an increased risk of thromboembolism associated with the direct oral anticoagulants compared to warfarin? Well, this has been, with temporary interruption, this has been studied in all the pivotal trials that got these drugs FDA requirements. And we know for dabigatran and rivaroxaban, it's equivalent to warfarin. In other words, 4 days of temporary interruption at the most would be okay. Apixaban, they didn't have enough data to comment on that. So what we now know to date is that there's no rebound hypercoagulability when you stop the drug and then restart it. We know that the FDA doesn't want you stopping these drugs for a very long time because they have very short half-lives, and the importance of restarting the drug as soon as the hemostasis is achieved is incredibly important. I get asked a lot about bridging. The bottom line, if you do not have a mechanical valve, you do not need to bridge the patient. That's the bottom line. It's been shown in large randomized controlled trials, including the BRIDGE trial and the ORBIT atrial fibrillation trial. But that only applies to patients who do not have mechanical valvular disease, okay? Restart the DOAC quickly after you've achieved hemostasis, and anticipate that the peak time to effect is only 2 to 4 hours. It's not like warfarin where you have 5 days, right? The drug doesn't need to load. It hits peak threshold at 2 to 4 hours. So often we do a procedure and we're thinking, I don't know if I've got immediate hemostasis. What should I do? So how do you deal with the DOAC? Here's the recipe. Again, if you think the procedure you just completed has a high risk of post-procedural bleeding or low risk, you do something different. For low-risk procedures and patients on apixaban, rivaroxaban, edoxaban, those 3 specific drugs, you can start the DOAC at full dose on the day after your endoscopy, okay? An evening dose if BID dosed or twice daily dosed. Dabigatran, which was the first drug available, was the only drug that actually did a proper study to look at how to reintroduce the drug after temporary interruption. And so we have very good recommendations for dabigatran. If it is a low-risk endoscopic procedure that you've done, you can restart that evening dose at 75, then the full dose the next day. For a high dose, you wait 3 days. And now the American Heart Society has said that it's reasonable to wait 48 to 72 hours. I don't have a clock, but I can see Miguel's face, so I'm going to get a little faster.
It's okay. No.
But I also see the translator saying, don't get any faster, don't get any faster.
It's okay.
I naturally speak very quickly. This is very slow for me. You should be on service with me as a fellow. They really have to run after me. Let's talk about the urgent GI bleed on DOAC. How do you reverse, okay? The most important thing to remember is these drugs have a very short half-life. Second most important thing to remember is that they're all excreted by the kidneys to a varying effect. The most by dabigatran, the least by apixaban. So the most important thing are the 3 concepts of GI bleeding: airways, bleeding, circulation, not airways, bleeding called GI. Right? You need to get them blood going through, volume going through, they will pee out the drug. A lot of bleeds are managed just that way. In the old days, we used to do hemodialysis with dabigatran because it was poorly protein bound, so you could get rid of it, but we don't need to do that anymore. For those of you who are in a setting where you might have suicide attempts with the use of these drugs, remember charcoal will impair absorption if given within 4 hours after ingestion. There's a little tip for you. Do you have reversal agents for these drugs in Mexico? Are you using those? Good. I have no conflicts of interest, so I can say I have not been impressed with these drugs. The one that's currently available is for Pradaxa or dabigatran. It's Praxbine. And it was approved by the FDA by a mechanism called fast track, which means the burden of evidence to get it approved is not very high. And what we do know is in vivo studies, it eliminated the dabigatran effect within 5 minutes of 2 IV injections of this drug given 15 minutes apart at a cost of $3,500 per dose to the patient, which Medicare does not cover. It was approved for life-threatening hemorrhage, but it was interesting, in the REVERSE-AD trial, there were only 18 GI bleeds. Very few of our GI bleeds are life-threatening. We really should be able to manage them with conventional therapy. If you have a neurologic injury, neurosurgical closed-spaced bleed, or a big motor vehicle accident with orthopedic injury, then this drug might make sense. Unfortunately, it's on the market, and cardiologists like that drug, like to tell their patients, we're going to put you on this drug even if you have a GI bleed. There's an antidote. But it's not the full story, right? There are 2 new agents that are being approved or will probably be approved in the United States by Christmas of this year or early 2019. So I think the whole paradigm is now going to shift away from these drugs being used for every case, but only in cases where they can prove that there is a high level of inherent anticoagulation in the patient. And we can do that now with serum assays. For dabigatran, a thrombin time, or better still, a dilute thrombin time, which you can get as an emergency panel in the United States, is very, very sensitive to telling you if the patient still has high levels of dabigatran in the system. The factor 10 and anti-inhibitors are a little bit more challenging because each one of those drugs, rivaroxaban, edoxaban, epaxaban, needs a specific assay. And even in the US, it's not common for all labs to have each assay. But there are a couple of back-of-the-napkin calculations you can make. If a patient has a dabigatran bleed and you see a normal APTT, or partial thromboplastin time, that pretty much excludes a toxic level of the drug. All right, so you shouldn't even be thinking about giving them a reversal agent. For the factor 10 inhibitors, if the patient is on rivaroxaban and endoxaban but has a normal PT level, prothrombin time, that in effect excludes a toxic level. The only one of those factor 10A inhibitors for whom that little rule doesn't apply is apixaban, because you can still have high levels with a normal PT. Personally, I'm not going to invest in these drugs in my stock portfolio because I don't think we're going to need them in GI, and I think they're going to have a limited shelf life. One very quick thing to remember about recurrent bleeding. With these DOACs, there is active drug in the GI tract lumen, even after first pass metabolism of the liver. So it's really important to minimize recurrent GI bleeding by doing a couple of things. Aggressively reducing any of the risk factors you see in the red box, knowing what's in the GI tract, which is why we see so much diverticular bleeding on DOACs, right? Because of the active drug that's still in the lumen. And know that in the elderly, all the risks are synergistic. So modify your risk factors when possible. So here's my last slide. Take-home points. This is a clinically relevant risk. There are a lot of new management paradigms with regard to resuscitation and use of blood products. There's better information now about how to temporarily interrupt these drugs, reverse and restart these drugs. And I don't think if your hospital hasn't invested in clinical reversal agents, you should be the first one to jump on the bandwagon. And remember, risk minimization really matters. And in our clinic, we've reduced rebleeding rates by 60% just doing the things on bullet number 3. Thank you.